Welcome. Welcome to another Health Management and Productions discussion starter. Today's topic is adverse selection. I'm Rick Cates and I'll be narrating this discussion starter today. So let's go ahead and get started. When we talk about adverse selection in a health insurance setting, this usually means when you know more about your likely use of health services than does the insurer. So what does the insurer do? The insurer deals with this problem by trying to design risk classes that group similar individuals in risk groups together. They then charge premiums that reflect this differential risk. As Rafat and I have mentioned before in earlier videos, if you're watching the final discussion starter video, or we could refer to as the culmination video for the entire section, you will have already read the chapter, gone through the PowerPoint, and in this particular case you have an additional video that you need to watch on adverse selection, which is done by New York University. Also, we will be starting the Power of Three, the discussion starter technique, and you will have 3 slides where you get to explain your material, and then you close with a summary question that will be put out on Blackboard to the entire class. If your group was assigned the Power of Three for this week, your 3 words are going to be asymmetrical information, adverse selection, and favorable selection. And I'll try to model this for you with a slide coming up. Here's an example of a digital image that you could use to express asymmetrical information, where one party has more superior information, or they think that they have more superior information, or that the individuals in this negotiation are not aware of the risk of the other individual. I took a few screen captures of where the New York University did a good job in their video explaining some of the terminology that we're reading about. So, if we're thinking about adverse selection and asymmetric information, if you look at the picture there, think of the buyer as the consumer. In a lot of cases, the consumer knows more about his or her likely use of health services than does the other, meaning the seller or the insurance company. The New York University video did a good job explaining insurance and the pricing of insurance. Individuals buy insurance for different reasons, and individuals have different perception of the risk that they're exposed to. They might buy insurance to mitigate a disruption to income or to negate a disaster. Pricing is very sensitive for the insurance industry. If you price insurance too high and you have individuals that are low income, low risk, or low users or utilizers of insurance, and you price it too high, they're going to come out of the market. Well, that leaves people that are willing to pay, but those people that are willing to pay tend to be high utilizers of insurance, and then the insurance companies are forced to raise prices again, and another level comes out that is not willing to pay for the insurance, again lower utilizers, and it creates this vicious cycle. This is a great image right here. So what insurance companies try to do is they try to get everybody into the same risk pool, high utilizers and low utilizers. So what happens is when you get everybody in the same pool, the low utilizers do not have a lot of healthcare expenses or hospital expenses, and their premiums offset the high users. But there's a problem. There's a catch-22. America is experiencing this dilemma right now because what's happening is the young, healthy Americans do not want to get into the risk pool or buy the bronze, silver, or gold plan. So this is an example, you could use this as an example of favorable selection. We want that young man with the inner tube around him to get into the pool to offset the risk. Well, the dilemma is that if they don't participate, they only have to pay, I think it's $90, $95 as far as a penalty for not buying insurance. So the price is low, and so they're not getting into the pool to offset the risk. The other dilemma that America is experiencing is that people will not buy insurance now because they know pre-existing conditions are covered, so they're going to wait until they're sick, then purchase insurance. So you don't have that premium that's in that pool offsetting the high users. I know I use a lot of phrases and definitions, or what I would call Rickisms, that you don't normally see in an academic setting. So let me explain one that I use quite a bit. I've heard Rafat use the same one too, a catch-22. So when I was describing the risk pool in the last slide, I used Catch-22, which is a famous book, but basically it's a paradoxical situation, a difficult situation from which there's no escape because of mutually conflicting or dependent conditions. Like the young man, is he going to get in the pool, not get in the pool? Why is he going to get in the pool or not get in the pool? So it's a catch-22 as far as his costs and his payments and his association to the risk as a whole. So the takeaway that we want you to have for this particular section is that you're able to look at insurance and you're able to look at favorable selection, adverse selection, what the insurance companies are doing, how they're pricing, when there is no adverse or no favorable selection. So let me give you an example. The New York University did a good job explaining a neutral type of insurance where insurance companies do not have to set up risk classes like in health insurance because they used rain. So rain insurance, you can look at the graph there and you can see that it's pretty consistent. So the insurance companies are well aware of the percentage that there will be rain or not be rain, and it can be easily measured with the rain gauge. So the individual that buys rain insurance, it's not going to be that they're favorable or unfavorable. It's pretty neutral. This is called indexing. It's a different type of insurance. So as you work through your Power of Three or you read additional information in the book, can you apply the concept of adverse selection, or can you figure out where you could have more favorable selection, or an example where you could avoid adverse selection? So you're a consumer or a buyer and you want to buy a car, but the person selling a car, they can in turn expose you to risk and sell you a lemon or a car with a problem. So you as a buyer, how can you avoid adverse selection? Well, one way is think about Carfax. You can go to Carfax, get the details about the car. Has it been in an accident? Has it not? And get some of the history on the car, thus mitigating your risk. So let's take a look at the HMO effect in favorable selection and tie that back to the journal articles that were in the PowerPoint. The conclusion from the Miller article was that people that are enrolled in an HMO use considerably less hospital care. Why is that? And what are some of the marketing strategies that these HMOs use to get the lower utilizing customers? How do HMOs keep people out of the hospital? They use effective utilization management tools. They may affiliate with physicians who are very conservative about hospital use, or they may provide financial incentives to the physician that leads the physician to admit fewer patients to the hospital. Another key component is they use favorable selection. They target specific groups that tend to be healthier. For example, an HMO may offer excellent maternity and baby care in hopes of attracting otherwise younger, healthier families. Another technique that goes after favorable selection is the HMO may offer a gym membership, or one that's new right now that's happening quite a bit is they'll give a free Fitbit, that bracelet that monitors the vital signs for individuals as a way to entice them to exercise and improve their health. PowerPoint provided several examples from several articles that provided evidence that supported HMOs using favorable selection and picking the very healthiest customers. The measurement tool used in most of the journal articles was hospital utilization, and consistently the HMO individuals used the hospital less or less frequently than individuals that had a conventional health insurance plan. Another issue worth mentioning in the HMO segment of the market is what is called shadow price. HMO will try to set the premium just a shadow below the competitive pricing of a conventional insurance plan. So essentially, the HMOs are siphoning off the low utilizers, and the high utilizers want to stay with the conventional plan because they want to pick their doctors, they want the additional benefits that go with having a conventional plan. So what happens? The conventional plan suffers because they may find that their claims experience now goes up, and the plan will have to raise its premiums accordingly to adjust. So I'm getting close to the end, and let me tie it off with some information about Medicare. Presently, there's an issue where Medicare HMO enrollees can switch back and forth from the Medicare HMO to traditional Medicare. This is another one of those catch-22 situations where, let's say you need a knee replacement or a hip replacement and you want the very best surgeon. Well, you can't use the very best surgeon or pick that one unless they're in the plan and you're in the Medicare HMO. Well, then you switch back over to the traditional care program, have the surgery, and then go back to the Medicare HMO. Finally, the book throws this one in, which I thought was kind of interesting. They call it an urban legend, which means it's not true. But what it said was that in Florida and New York, that there was this Medicare HMO that set up its enrollment office on the 3rd floor. So people had to walk up the stairs, and any senior that could get up 3 flights of stairs was then enrolled in the HMO, which then in turn lowered their cost because why? Favorable selection. Closing. Who's getting in that pool and why they're getting in that risk pool. Thank you.